Good afternoon, everyone. Welcome to today's Research America Alliance member web meeting. Thank you for being Alliance members as always, and also for joining us today. I want to also welcome guests who may be joining us from the New York Academy of Medicine. So we have instructions to mute and unmute your lines on the screen. You know the drill. Type your questions into the question box at any time, and my colleague Terry will ask those at the end. If you're dialing in by phone, you can hit *6 to unmute your line and ask a question at the end. So our very special guest today is Dr. Judith Salerno, President of the New York Academy of Medicine. And among her many distinctions, Dr. Salerno served as President and CEO of the Susan G. Komen Foundation, the Leonard Schaefer Executive Officer at the Institute of Medicine, now known as the National Academy of Medicine. And she was also the Deputy Director of the National Institute of Aging at NIH. So Judy is going to share her personal experience as a first responder, really giving us a sense of the human impact on both patients, family members, and physicians of the pandemic, and also a sense of the on-the-ground impact of the research and public health advocacy that we are all working so hard on in Washington. So Judy, thank you so much for your willingness to share your experience. Let's start at the beginning. There was a call for more clinicians to treat COVID-19 patients in mid-March. What thoughts were running through your head when you heard this? I mean, what urged you to come out of clinical retirement to help?
Thanks, Jenny. I'm really happy to be here with you, and we are a Research America member and proud of that as well. When things started to really get bad in New York, I was, as we all are, in my home office, which was my bedroom, Zooming from meeting to meeting, and we were only several blocks from one of the major hospitals in New York, and all I heard all day long were sirens, and they were ambulances going up and down 2nd Avenue. And I actually took out my medical school oath that I took 35 years ago, and words in it really resonated. It said, "Respond always in an emergency." So I felt that I had a skill set. There was an overwhelming need, that the systems were being swamped, and that I had to step up, and I did.
So you treated patients at Bellevue Hospital in New York City. How would you describe Bellevue and also the patients and the unit where you were assigned?
Yeah, well, Bellevue is the largest public hospital in New York City, and it's also the oldest public hospital in the United States. So it has a storied history, but it treats really, it's a safety net hospital. And when I first volunteered, I requested that I be at a public hospital because I knew that that's where the greatest need was. So I was actually called by Bellevue and Metropolitan. Bellevue called me first. I went down there. Took me about 2 weeks to get all my emergency credentials and to get onboarded. And then I asked to be assigned to the palliative care unit because I thought, as an older woman, that I could do a lot of the work virtually by teleconference. And it turned out that that wasn't exactly the case, because our palliative care unit was assigned full-time to work in the COVID ICUs. By the time I got there, there were 7 ICUs full of COVID intubated patients. And it was startling to see that areas like endoscopy suites were converted into ICUs, halls, patients everywhere, but 100% of the ICU patients were intubated. And there were very sick patients who we were trying to avoid intubation out on the floors. So we decided we could do, as a palliative care team, the best good, the greatest good, by working with the ICU teams because they were so overwhelmed, and that's where we went.
So The doctors and nurses on the floor learned a lot about the disease really in real time, right? I mean, so in the early days, it was thought to be an acute respiratory distress syndrome, but that understanding shifted too. And did it also impact the treatment that the patients were given while you were there?
Well, unfolding before our eyes, we saw patients having events that were unexpected and unreported. So that about a third of our patients needed to be dialyzed because they had kidney failure. And patients were having strokes, MIs. They were clotting off their limbs. So we were seeing necrotic toes and amputations that needed to be done acutely, things that we had no idea because we thought we were dealing with essentially a very difficult respiratory illness, but it was a multi-organ failure that we were facing. This was weeks before these things were reported in medical journals. So we were flying by the seat of our pants, and it was frightening, and we didn't know really what to do at times. But we started seeing a pattern like the kidney failure, and then followed by trying to get as many dialysis machines as possible, and then seeing patients. We ran out of filters for the dialysis machines. We ran out of supplementary oxygen. We ran out of just about everything because everything overwhelmed the system so quickly.
So the clinical information about patients was coming so quickly. How was it shared? I mean, both within the hospital, but also across hospitals. Were there some informal networks that were sharing clinical information?
Yeah, we had a morning call every day. There was a system-wide call, and then a hospital-wide call, and then a service-wide call. So we checked in first on what was going on across the city, then with what was happening in the hospital, and then we got reports that, today we have 115 intubated patients and 275 COVID patients. I mean, astounding numbers. And then we went our service, in the first week I was there, the palliative care service generally had between 20 and 25 patients. We went up to 90 patients our first week, and we were only dealing with the sickest ICU patients that needed family support and our support. And we had to break that down. We broke down into 4 teams so we could manage this. So then we, every morning after this, we shared our information and then went on our teams. But we also had, we rallied a number of people from the Health and Hospitals Corporation in New York City, and someone from the New York Academy of Medicine, and we put together daily updates, which provided us synopses of the latest journal articles or the latest information, because things were coming at us so quickly. So every night I would try and read those updates, but I didn't have the time or the energy to go through journals. So these synopses really, really helped. And we contributed to that too with our knowledge of what was going on within our service.
Do you remember a time where medical information was changing and being shared in real time like this?
Never. In 35 years in the profession, never. However, a lot of the information was coming from, disparate sources, and some of it was really inaccurate. And we suffered from that. And the guidance, the CDC guidance, for example, changed within 3 times within the time I was at Bellevue for over a 5-week period. And it was very difficult because we were looking to that guidance to tell us, for example, if one of our team members tested positive, when could they come back? And first it was, well, if they're asymptomatic, they can work. And then no, they had to stay out 14 days, and then no, you had to have 2 negative tests. And this changed all the time. So it was really hard to plan for, a large clinical service when you didn't know, you didn't have guidance that you could rely on, because it was like the sands were shifting under our feet all the time.
And I'm assuming part of that was because the CDC's information was shifting as well.
I
Yeah,
think, we were all learning on the fly. And
right.
it was not that I think people were intentionally putting false information out there, that we were just learning, and there was
Right.
so much to learn so quickly.
So the PPE was a big issue, at least as the news reported, and those of us who have friends in clinical practice, heard stories about the scarcity of PPE. How was it at Bellevue? Was it as dire a situation as has been reported?
Well, when I first reported for duty, I was given one N95 mask, and I was told to take good care of it. And I didn't get another mask for a week. I had friends from someone as far as Hong Kong send me an N95 mask. And what I tried to do is I accumulated over time 5 masks. So I had a mask that was my Monday mask, a Tuesday mask. I put them in little brown paper bags, and I hung them up in the office with my name, because, the first week I used one mask and saw over 100 COVID patients that week. So it was very short. I had a face shield that was created by an architectural firm in Brooklyn on their 3D printer. Alcohol wipes were really scarce. Purell was plentiful, but it was very frightening, because we had to protect ourselves because we were the caregivers, but we also wanted to protect our families.
Wow. So let's talk a little bit about the patients and their families. And I know from our prior conversation, this is hard for you to talk about, but you took on the responsibility of communicating with the families of the patients because they were unable to communicate. The family members couldn't visit the hospital, and the patients were incubated and intubated, and so couldn't even get on the phone with a family member. So can you describe what that was like?
Well, I came to feel that while I rounded on our patients in the ICU every day, my real patients were the family. I was trying to take care of the family. I was the only link to their loved ones who were dying in the hospital. And I called the families every single day. And I like to say that, not many of them remembered my name, but they always knew my voice. And when my phone number came up on the phone, they picked it up on the first ring. And sometimes they would have organized a conference call if they knew I was calling at 2 o'clock, where they had 10 family members there. But it was often really difficult to find family members. It wasn't unusual for someone to come into the emergency room and immediately need intubation. So we had whatever they had in their bag or their wallet as information. And some of it was not, we couldn't find family members. Sadly, of the hundreds of patients, I only saw one patient who was not a person of color the entire time I was there. I only had 2 patients the entire 5 weeks, full-time 5 weeks, who came off a ventilator. And I only saw one patient that I personally could communicate with. But I tried to, the chaplain service was really good in helping us. We tried to hold up iPhones and FaceTime with the families, and the families spoke to the person, and they would swear that the person responded to them. Half of the families I worked with didn't speak English, so I worked with a translator, and it was really very sad because I was trying to tell them in a gentle way through a translator that their loved one was dying, and they just couldn't accept that because the previous week or 2 weeks this person had been healthy. Often I was talking to a family member in another country, in a village in Mexico. I had one patient whose family lived in Ecuador, and the village he lived in took up a collection for medicine. They wanted to send us money so we could buy medicine for this patient. Their operating assumption was that because this person was poor and frankly undocumented, that they weren't getting all the care they could, that they were getting less than. And it was really hard. It broke my heart to have them do that. And you know, we sure didn't accept any gifts or any money, but and to tell them they were doing everything we could to save their loved one's life, and most of them didn't make it.
Well, the disproportionate impact of COVID-19 on people of color is a crisis all its own, and it sounded like that really impacted your experience heavily at Bellevue.
It was primarily what we saw were people of color, you know, patients who were living, who were here working in kitchens or construction, and they lived in an apartment. One of my patients lived in an apartment with 8 other men. They were sending money back to their families in Central America, and you know, in some of these neighborhoods, the infection rate was very, very high. In some of them, they, you know, didn't know that they were entitled to get care in the public system, no matter what their legal status was. So they delayed care, and in other cases, they needed to make money, keep making money, and they took public transportation, and you know, all of these things. Crowded housing, lack of resources and access, it all contributed, but it was primarily people of color who we saw at Bellevue, and they were so sick by the time they came in. And we were getting transfers from other hospitals too, who couldn't, they were overwhelmed. Patients were out in the hall, and we were adding on ICU beds all the time.
Well, caring for so many sick patients, and I think that sense of being able to do so little often really had an impact on providers, on doctors and nurses. And you spoke about, you used the words moral injury when we spoke yesterday. Could you talk a little bit more about that and the experience of, you know, early career physicians and nurses?
Yeah, I was really worried about the house staff we worked with. And in the first week I was there, they took a month-long ICU rotation and shrunk it down to 2 weeks, because these young doctors, and some of them were 4th-year medical students who were graduated early. Fellows were elevated to attending status. We had volunteer doctors coming in and out, and they, you know, they saw so much suffering. And it was unimaginable what we saw and what they saw. And I couldn't imagine, as your first experience as an MD, as a doctor, going through this. We, you know, we all tried to take care of them and take care of each other. But I think that there was so much that we couldn't unpack at the time, that I think it's going to come back. And I know it's something that has affected me. We would come in the mornings and talk about our dreams and talk about, you know, they were really nightmares. They were COVID dreams that were so real. None of us could go directly home. We would, you know, I walked home 2 miles every day because I needed to decompress. So we tried to do what we could, but there were many house staff at the breaking point, and some who had to take leave because it was just overwhelming. It was unrelentless, and there was such scarcity, and the feeling of we were helpless because we didn't know what to do. And these, the renal failure, the MIs, the thrombotic events, the strokes, all of it were unfolding before us. And it was like every time you turned a corner, there was a new situation. So I worry about these young doctors and the long-term effect, because they were burnt out after 2 weeks. And I don't know, I mean, I was burnt out, and I can't imagine that these young doctors, this is going to have an influence on them for the rest of their careers. It's seared into your memory. It was really, it got to your soul, and I just couldn't imagine being an intern and seeing what they saw.
And we know that even though New York may be not at the apex anymore of its crisis, and hopefully won't get back to that point, this is going on in states and cities across the country, crowded ICUs and et cetera. We're gonna turn to questions. I just want to ask one more question before we do. So since you were at Bellevue, we have some better evidence about certain medications, some different treatment protocols, putting people on their stomach and not their back, et cetera. What is your sense of what it would be like if you were to go back now, or what do you hear from colleagues? Has it gotten, I don't want to say easier, but and I guess, is there more clarity now in terms of treating COVID-19 patients?
Yeah, we all, those of us who were there at the apex and who are not there now, consider ourselves on pause. And we hope that that pause never ends, that we don't have to go back. But we know so much more about what to expect. We know, and we can be prepared. There can be enough dialysis machines, and there can be enough expectations. We anticoagulate patients now, so that will help with thrombotic events. We have dexamethasone and remdesivir. We only had 2 patients the entire time who were able to get on that protocol. So there's so many more options for treatment. Not that it isn't still a serious fatal disease in many respects, but we know that there are things we can do to keep people off ventilators, because people don't survive when they get on ventilators very often. And so I feel optimistic about, and I hope that people learned from our terrible experience in New York and are putting that experience to good use. I wish that we had known more about the Chinese experience in New York, because they knew. I read later that there were articles published about kidney failure and things like that, but we didn't know. We didn't. So maybe that will help.
Interesting. Wow. More than interesting, just devastating. Terry, do we have any questions in the question box?
We have one, and I can also remind our audience to go ahead and type the questions they have in the question box. The first question we have, let me pull this up. Thank you, first of all, Dr. Salerno, for stepping up. It is frustrating to read news stories with quotes from folks who are already saying they're going to refuse to take a vaccine should one become available. Any thoughts about what we can do as educators, advocates, communicators, healthcare professionals to make sure that enough people get the vaccine so this disease will be defeated? Your story is so helpful.
Well, yeah, I think it hurts those of us who saw the worst of the pandemic in the hospitals. I think this hurts us maybe a little bit more than it hurts those who know the public health impact. It's frightening. People who don't wear masks, all of this is, I think we have to, as public health advocates, just keep hammering at the message. I said yesterday to Jenny that maybe we need to get more of, the celebrities who people believe, since they're not as trusting as they should of public health advocates, that maybe that we need to just get out there with lots of different people telling the message and, telling us what to do. But I do think that, when I was at Institute of Medicine, I was pilloried by the anti-vaxxers about the autism question because we had done a lot of reports. You just have to be as relentless as those who are seemingly intractable are. You just have to keep pushing with the message.
Thank you,
Great,
Judy.
thanks. One other question. Many of those on the call are working hard to advocate for funding to develop more COVID-19 treatments, improve our public health system, and maintain our research labs. What would you like us to be sure to take away from today's conversation?
Don't stop. Redouble your efforts. We have to be out there. Every time I have an opportunity to sign a letter of support or advocate in some way, I do it because, the consequences are too great and too grave. There is, we have to maintain hope. We have to make sure that we understand that the consequences are long-term for this, that it's going to take us a while to get over this. So we have to do everything we can to make sure we have the treatments, the vaccine, the public health measures in place, and just stand up to the naysayers and continue to do so.
Well, Judy, I think that is a very good place to stop. I want to thank you for being with us today. I mean, not only did you serve on the front lines, but you are continuing to. Oh, I hear we have another question from. We always like to ask the questions of our participants. So, Terry.
Well, first of all, I have many comments simply of just pure appreciation. But one other question. First of all, again, thank you so much for sharing your experiences. And have there been any psychological support programs for the staff?
Yes, there have been. And actually, a couple people who I worked with have had to take leave and stay out on leave because of the emotional trauma to them. There's been a lot of everything from podcasts, which I listen to, called Decompress for healthcare workers. There have been a number in New York State, mental health practitioners who've offered services. But I think that the key thing is that we all who served during this time keep in touch with each other and keep supporting each other, because it's a very isolating feeling to have been through this and to know what it is, and people have not had the same experience, people around you. So there's a sense of isolation. And I've told that not a lot of people are taking advantage of the mental health resources, but I think that this is going to, roll out over time. I don't think it's something that appears in a day or resolves in a short period of time. So I think the consequences are longer term, and we have to be prepared, and we have to particularly support our young health professionals who were so incredibly brave.
Well, as doctors and nurses, you're oriented towards taking care of others, being providers, and not necessarily taking care of yourselves. So I know that is part of the challenge in seeking help. Well, as I was starting to say earlier, thank you. And thank you for going back into clinical practice and really literally putting your life on the line. But also what you're doing now, because I think while we do see news reports and we read about it, I mean, having a dialogue with you is just so impactful. So really, thank you from the bottom of our hearts, and we look forward to staying in touch with you, and we'll be certainly sharing your message. Thank you, Judy.